Hello, everybody. This is Melanie with the Davis Phinney Foundation, and I'm excited to have Dr. Maya Katz with me today. Hi, Maya. How are you?
Good. How are you?
Great. I'm going to give you a quick little intro. Dr. Maya Katz is an associate professor at the University of California, San Francisco Movement Disorder and Neuromodulation Center. She obtained her medical degree at Cornell University and completed her residency in neurology at Mount Sinai Medical Center, where she served as chief resident. She then completed her movement disorder fellowship at UCSF. Dr. Katz's research interests include palliative care, comparative effectiveness studies to optimize quality of life for those with Parkinson's and related disorders. Her research is also focused on identifying neuroprotective strategies for Parkinson's and related disorders, as well as improving outcomes for people treated with deep brain stimulation. Wow, great. So excited to have you here. Her talk today is not just the shakes, non-motor symptoms of Parkinson's. Thank you. I will be, as usual, monitoring the chat box. We're not going to have questions at the end of this session, but I will take them and hold them for this afternoon's panel. Okay?
Okay,
So there you go.
sounds good. All right. Well, thanks everyone, and excited to be able to continue doing this kind of a talk in a different forum with these unprecedented times, and hope everyone is staying safe and healthy back home. And thanks for joining. Okay, so what we know now is that motor symptoms are really just the tip of the iceberg in Parkinson's disease. And that's because there are a number of other symptoms, as you in the audience with Parkinson's, care partners of people with Parkinson's already know. But for doctors, for medical people, it's actually kind of a newer idea that people with Parkinson's have significant non-motor issues. And so it's been, I think, a learning curve in my field. And I think just talking about it here will also help encourage people to talk about it to their doctors. So we can really fully address and just better address non-motor symptoms. And so the topics we're going to talk about here, and these are just a few of the non-motor symptoms that people might experience. And so I just picked them because they're common and they're ones that really affect quality of life. So I'm going to talk about dizziness, fatigue, insomnia, dream enactment, constipation, pain, and then overactive bladder symptoms. So dizziness. So dizziness is really this vague term, and people can mean dizziness from a lot of different reasons. Sometimes people talk about dizziness as a spinning sensation or just a general feeling of unwell. In Parkinson's disease, usually people say they're dizzy if their blood pressure drops and they're feeling lightheaded. And that's because of a condition called NOH, or neurogenic orthostatic hypotension, which it's just easier to say NOH because it's a mouthful otherwise. So the big reason why people get lightheaded when they stand up with Parkinson's is because blood pressure, which should increase when you stand up to fight gravity, actually decreases, and blood actually pools in the legs, and people can't get enough blood flow to their brain, and they basically feel lightheaded. It's that simple. And so the way we combat that is really by trying to increase how much people are staying hydrated. Hydration is a big problem. Just in general, people don't stay hydrated. You really want to make sure you're drinking 6 to 8 glasses of liquid daily. And I always recommend that at least half of that be non-water, because water is actually one of the least hydrating fluids. You really want to do something like Gatorade or Powerade, or anything with salt and sugar, basically. So V8, tomato juice, coconut water, anything with electrolytes. It's going to be much more hydrating. It's important. You want to change position slowly, sit up, just wait. And then, some people even wait for 15 to 30 seconds and then stand up and just wait. So you don't want to just kind of bounce up from bed and just go, because the nervous system has to kind of do its best to try to increase blood pressure when it's fighting gravity. So you want to give it the best chance to do that. You want to make sure that you're avoiding prolonged exposure to hot weather, so staying cool. And you want to, sometimes people, if they eat large meals, it'll be worse. So you can try eating small, low carb meals. and then also caffeine. So drinking 1 to 2 cups of coffee will also help increase your blood pressure when standing. And so those were just the non-medication suggestions, and these are the medication suggestions. So one, a lot of the times people will be on blood pressure medication because they have high blood pressure. And then with Parkinson's disease, they have to be taken off of those blood pressure medicines because they no longer need them, because in Parkinson's disease, they have the opposite problem. So we're trying to increase blood pressure. We're trying to increase salt. We're like the opposite of most doctors. So, you know, salt in our world is good. Of course, you want to talk with your doctor first. You don't just want to stop your blood pressure medicines and eat a lot of salt. If you have a heart condition or something like that, you want to make sure that you've talked with your primary care doctor, your heart doctor, to make sure it's safe. But having salt tablets with every meal can be very helpful to increase blood pressure. And then I listed a number of medications. So really with all of our treatments these days, it's very uncommon where we can't control the symptom. Really, you shouldn't be dealing with lightheadedness, fainting, near fainting episodes on a regular basis. These are symptoms, you know, this is a symptom that really can be solved with good management, medication and non-medication management. So really be persistent with your doctor to make sure that they're trying everything they can to treat the symptom. And what about fatigue? Fatigue's the next symptom that I want to talk about. And fatigue is a really common part of Parkinson's. And it's also one of those kind of vague symptoms that's hard to describe, hard to really kind of wrap your head around. And so sometimes it's people don't report it to their doctor. And so it's something that is that we would like to hear about. It's important, you know, when someone has fatigue, think about, you know, are you sleep deprived and that's why you feel tired? Is it the sleep issue? Is it depression? Fatigue is a big part of depression. And so we don't treat the fatigue, we treat the depression, the fatigue gets better. So, and fatigue can also be a medication side effect. So you want to talk to your doctor about the symptom, have them review your medications. And then there are some other ways to help with fatigue. I have to admit that it's one of those symptoms that if it's not from sleep deprivation or depression or medication issues, and if it's just a plain fatigue from Parkinson's, that's one of the symptoms that can be tougher to treat. There are a few things that I'd like to talk about though, that can help. So one is something, just regular exercise. Even if you don't feel like it, do it, because otherwise you'll get into this vicious cycle where you don't feel like you have enough energy to do activities and exercise, and that makes you actually feel more fatigued. So you really have to kind of force yourself and tell yourself, this is good for me. I really need to go. Strength training, group exercises are good because other people around you will get you excited and motivated. It's hard to do when some of us are in quarantine, such as myself in San Francisco, and a lot of us are around the country. And so there are some online exercise classes that are just for Parkinson's disease. And you know, that might be something to think about. There are some exercise bikes and pedal devices that actually force you to go a little bit faster than where you think you should be going. And that's a kind of a forced exercise. So you can generally go faster and longer in exercise than you think you can. And forced exercise has been shown to help reduce fatigue. Yoga is good at building stamina. Acupuncture has been shown in a clinical trial to actually reduce fatigue in Parkinson's disease. Both acupuncture and sham acupuncture worked in the study. And by that, I mean that in the 50% of people got real acupuncture and 50% of people had a college student poke them with toothpicks in different parts of their body while they were blindfolded. And actually both the sham and the real acupuncture worked. So turns out it's not the actual acupuncture that's helpful in fatigue. It's maybe just, you know, some other part of just being, you know, spending the time focusing on that symptom with an individual who's also focused on it with you, possibly. We're not sure. But real acupuncture does also work for fatigue, and so I do recommend it. And then mindfulness can be helpful. You know, if there's a thought or a feeling of fatigue in the brain, then you can reshift your focus. And maybe, you know, that'll help you do some of the exercises, kind of acknowledge the fatigue but pivot and try to just push yourself through. There are some herbal medications that have been shown to be helpful for fatigue, like caffeine, L-carnitine, creatine, and ginseng. So these all actually have clinical trials that show that they've been helpful for fatigue. And there are some prescription medications that I've listed that are, the first two are, you know, essentially amphetamine derivatives. And so they have potential side effects of, you know, excess energy, kind of anger, irritability. I don't usually see that. Most of my patients actually do well with these medications, but they are, you know, definitely bigger guns than the herbal medications. So I would start with non-medication type treatments like the ones listed here, and then some of the herbal medications before going to the prescription medications. And what about insomnia? Of course, insomnia is a big issue in Parkinson's, and it's a big issue in older adults in general. And so it's really important to maintain good sleep hygiene. So we always want to do non-medication interventions first. So you want to keep a regular schedule. So it's important that you go to bed around the same time and you wake up around the same time. The brain really likes that kind of a schedule and wants to be on a 24-hour schedule. That's just how we evolved. You don't want to have any caffeine, nicotine, or alcohol 4 hours before bedtime. That will disrupt your sleep. And you want to avoid exercise, really heavy exercise, a couple of hours before bedtime. Exercise in general is really good for sleep, but not 2 hours before bedtime. And you want to make sure that the room is quiet and dark. You don't want to have a TV on while you're trying to go to sleep, which is what happens to a lot of people. You want to take the TV out of the bedroom. You don't just want to go to sleep on the reclining chair as the TV's on while you're in the living room, dozing off and on. That artificial light from the TV is very disruptive to the sleep hygiene. And you want to make sure that when you wake up, you want to get sunlight in the morning. First thing in the morning, you know, looking out the window and just getting some sunlight for, you know, even just 10 minutes can be very helpful to just reset the clock. Reset your clock for another 24-hour day, and it's just very important for good sleep. A few other things that you want to figure out for insomnia is, for many people, they have sleep apnea, and actually people with Parkinson's disease are at higher risk of having sleep apnea. Usually people have to, the main risk factor for sleep apnea is typically being overweight or obese. But in Parkinson's disease, people actually can have, you know, normal body mass index, so they're not obese or overweight, but they still have sleep apnea. So that is something that you can get tested for, and if you have sleep apnea and you get treatment for it, people usually feel a lot better because they're getting good sleep. And there is cognitive behavioral therapy for insomnia, or CBTI. Medicare and insurance will pay for this. These are therapists who have specific training in insomnia and cognitive behavioral therapy. CBT for insomnia has been shown to be more effective than any of the medications in helping insomnia. It really should be the first line. And what it does is it helps you develop that really good sleep hygiene with a therapist for a month. You're keeping track of your sleep hygiene, and the therapist is working with you by phone a few times a week to just make sure that that sleep hygiene is as good as it can be before you, you know, move on to any type of medications. I have listed medications that we do use for insomnia. First thing is to make sure that you're taking some kind of dopamine medicine at bedtime. Now, that is with a caveat that for some people, actually taking Sinemat at bedtime or Rytary at bedtime, dopamine, makes their sleep worse. So there is a small group of people where that happens. But for the majority of people, we really need dopamine to sleep well. And so taking a Sinemat or Rytary, which is the longer acting form of Sinemat, which I prefer at bedtime because it's a longer amount of time, and then adding in some melatonin, those two things should happen first before we do any other medication changes. Because for 90% of people, just adding in a Rytari at bedtime and adding in some melatonin, they'll sleep a lot better. I've listed some of the safe sleep medications in Parkinson's disease. Some of these medications we're using off-label. They were created for a different purpose, but now we primarily use them as safe sleep aids. And so these are just some of the medications that you can talk about with your doctor, and just to know that there are safe sleep medicines that your doctor can put you on to help once you've tried just adding melatonin, Rytari, and making sure that your sleep hygiene is as good as it can be. And we'll just go on to dream enactment. And some of you may not know what I'm talking about when I say dream enactment. So normally when people dream, our brain actually paralyzes our body so that we don't act out our dreams. Otherwise, we would all be, you know, if we were being chased by a bear and running away from the bear in our dreams, we would all be running like this in our beds. In Parkinson's disease, about 50% of people are not paralyzed in their dreams, and so they actually act out their dreams. So if they're flailing or kicking in their sleep, particularly if the dream is an highly active dream. I had a patient that, for example, was chasing a Pokemon in her dream and had a dream enactment where she, you know, jumped out of bed to chase the Pokemon because she was jumping to chase the Pokemon in her dream. That's an example. So we call that dream enactment. The medical term for that is REM behavior disorder. REM, rapid eye movement, is the phase of sleep where we're dreaming. And RBD, it's a behavioral disorder during dreams, basically. I have had some patients, you know, because it is aggressive type movements, that are worried that it means that they're an aggressive person. I have had a patient who actually went to therapy because they thought they were aggressive and it was somehow coming out at nighttime towards their partner. None of that is true. It's not saying anything about your underlying personality or some kind of deep-seated aggression. None of that is true. It is just a neurological issue where the brain is not paralyzing the body. And so fortunately, it's actually very easy to treat in almost everyone. So 99.9% of people, this is treatable. The first thing, of course, I always want to focus on is non-pharmacological treatments. So move sharp objects away from the bed. Okay, you don't want to have, bed stands with really sharp edges around the bed. You want to move that away, or you want to have bed stands with round edges. You can if you can lower the bed, the better. You know, this is because people, when they're having dream enactment, they can actually fly out of bed. They can hurt themselves. In my mind, this is one of the most dangerous symptoms of Parkinson's, because, for example, my patient who jumped out of bed to catch a Pokemon actually fractured her clavicle because she landed. When she jumped up, she had to, come back down, and unfortunately she had an injury. And so this is a really, really important part of Parkinson's to talk about with your doctor and to get control over, so you don't have these types of injuries. Bed rails are not recommended because people, if they're jumping in their dreams, they're going to jump over a bed rail. So actually bed rails can cause more injury for people who have dream enactment. And one important thing is that antidepressants can actually make dream enactment worse. So if you're starting an antidepressant and you notice the dream enactment got worse, that might be from the antidepressant. Medications, melatonin, again, just a natural hormone. 3 or 6 milligrams, a low dose of melatonin in almost everyone will control this symptom. Melatonin is important in the way that our body paralyzes us during dreams. So if we take a little bit more for people with Parkinson's because they don't have enough melatonin, it can be very helpful, and it can just completely resolve this situation for most people. If melatonin is only partially effective, then we typically add clonazepam, and that essentially rounds us up to close to 100% of people can be treated with those 2 medications to help control RBD. And so sometimes, partners will sleep in separate beds because of this symptom. And so I think that's not a good, that's not good for kind of closeness and connection in the relationship a lot of the times. And so just giving someone, just taking melatonin, clonazepam, and some of these other precautions, then people can kind of stay in bed together longer as a couple. Constipation. Okay, very common issue in Parkinson's. And why is that? Well, that's because Parkinson's affects the gut. We see that there are, throughout the gut nervous system, and the gut has its own nervous system, there's evidence of Parkinson's affecting it. And so the stomach and the intestines, just like the muscle movements are slower in Parkinson's, the stomach and intestines also move slower, so that everything kind of moves slower through the gut. So a few things to keep in mind. Let's talk about natural and non-pharmacological, non-medication things first. So you want to stay hydrated. Again, hydration, prunes, high fiber diet, just changing those things. Prunes, try to have 5 to 10 a day. And with a lot of my patients, I try not to give them more medication for constipation, because people are already on so much. So if you can just have prunes and a high fiber diet, for a lot of people, that's enough. You also can add a probiotic that's been shown to improve constipation. Caffeine, 1 to 2 cups per day. So notice I'm talking a lot about caffeine being helpful for some of these symptoms. I know that it can also worsen tremor for some people. So you have to see for yourself, is it worth, does it help more than, causes the tremor to be worse? And for some people, it doesn't affect their tremor, and they can just take some caffeine to help with some of these other symptoms. Magnesium is just a natural compound that you can take to help with constipation. And smooth move tea, which is senna. Senna is a medicine for constipation, but it's also just a natural plant, and that you can drink as a tea. And although I haven't tried it yet, it's on my to-do list to try. I've heard that it's a delicious tea. And so try these natural remedies first. And of course, keep moving. Regular exercise is really, really important to keep the gut moving. These are the medications that I typically use: Senna, Miralax, Dopalax, and Linaclotide, Linzess. And basically the idea is to try to find something that you can be taking every day to stay regular. You want to stay ahead of constipation. You don't want to be relying on suppositories and enemas. If people have constipated for, a few days or a week, then that's just much harder to treat, just like anything. And any symptom is easier to prevent than to treat, especially treating it once it's really severe. So the focus of constipation management is to get on a regimen that will help you, and to take something on a daily basis rather than waiting and chasing the symptom. And that's going to be true in general, especially in pain management. So there's different types of pain that people with Parkinson's can experience. And I think this is a really, often, this is a symptom that, we don't usually talk about. And so it doesn't get treated as much as it should. And just know that, Parkinson's can cause pain, and there's different reasons for it. I wrote here arthritis. Obviously, arthritis is something that causes pain in older adults, whether or not they have Parkinson's. Parkinson's just can make that pain worse. So that's why I listed that symptom. In general, you want to reduce the off time. If someone has arthritis and Parkinson's makes that pain worse, it's going to be worse during the off time. If you can take longer acting levodopa compounds like Rytari or other ways to reduce off time, the pain will be better. Mindfulness-based stress reduction is a technique that's specifically shown to reduce pain. Acupuncture can be helpful. I put duloxetine, which is an antidepressant that also helps with pain. Tylenol, people forget, just to take standing Tylenol can be very helpful and very safe. And then I put, just because I know it's going to be on the mind of all the listeners, CBD, because I know we'll be asked about it, and why didn't I put it on here? So I added it, although, you know, I'm not sure. I think some people find it helpful. I think it's safe to take CBD predominant compounds. I wanted to talk about central pain disorder, central pain syndrome, and Parkinson's disease. So this is a specific Parkinson's related pain condition that happens when the medicine wears off and is gone when the medicine is working, and is usually kind of vague, tingling or burning type pain that's hard to describe for people. And we call that central pain syndrome. Really, the main thing is to reduce off medication. I put mindfulness here, acupuncture, and then I put the, you know, some other pain treatments, duloxetine and cannabidiol, but really the main thing is to reduce off time. And you really want to talk to your physical and occupational therapist to develop an exercise and movement strategy that can help reduce the pain you're having and reduce any type of injury now or in the future. The best thing to do is to talk with a physical and occupational therapist to understand what kind of exercises you want to be doing. Because now we know that when people are in pain, kind of, you know, just sitting and being immobile is actually typically not good for pain. We want to keep people moving, but we want to make sure they're moving safely. And I also wanted to talk about abdominal pain, which we don't usually talk about a lot, but there is a condition called SIBO, which is small intestinal bowel and bacterial overgrowth, that can cause a lot of cramping and bloating pain, and that we can treat now with, we give it a certain antibiotic where we get rid of the bad bacteria that's causing those symptoms, and then we give a probiotic so that the gut has good bacteria. And that is really effective at treating abdominal pain in Parkinson's disease. So please talk to your doctors if you're experiencing that. And then finally, we'll talk about overactive bladder symptoms. And so, you know, basically you do want to just make sure that you don't have a urinary tract infection or an enlarged prostate. Those are things that you can have, that you can check with your doctor that can cause these symptoms. If it's not, you know, may not just be Parkinson's disease. For people that do have Parkinson's related overactive bladder symptoms, a lot of the times we just tell them, just go to the bathroom every 2-3 hours during the day. That way you're ahead of the bladder urgency symptoms. Kegel exercises where we strengthen the pelvic floor muscles are highly recommended, but for some reason not commonly done. But I really do recommend trying them every day. Nobody has to know that you're doing Kegels. And so I would, you know, encourage you can actually talk to your physical therapist about learning how to do proper Kegel exercises, but they can be really helpful at just giving people some extra time to get to the bathroom. You do have to do them every day, and it takes about a month and a half before you get any benefit. And so people usually give up before they get benefit, but I do recommend it. And I mentioned pelvic floor physical therapy. These are physical therapists that are really focused on teaching people how to do good Kegels. They do exist, and they're very good. And you want to limit liquids 3 to 4 hours prior to sleep. Medication-wise, you really want to make sure that you're taking the right medications. I put oxybutynin. This is an old drug that we used to give for overactive bladder, but I see people coming in for for initial visits to my office who've been taking this medicine for a long time. Oxybutynin is dangerous in Parkinson's. It increases the risk of developing dementia in Parkinson's, and really should not be used. I listed the medications that are actually safe to use in Parkinson's. And so there are a number of safe medicines to use. And so, please talk to your doctor about that. They may tell you all of the medicines are not safe, and that's not true. There are safe medicines to use for overactive bladder. So please talk to your doctor about that. And then there are a few procedures that we also have that can be effective that you can talk to your doctor about. There's actually electroacupuncture for overactive bladder symptoms, where they just stimulate a nerve in the side of the leg. And that also helps strengthen the just the nervous system response for bladder emptying. So in summary, action steps: talk to your doctor about any symptoms you're having, Try lifestyle changes first before adding medications. Focus on prevention. Remember, prevention is going to be preventing a symptom is a lot easier than treating it once it's really full blown. And exercise for at least 150 minutes per week. I wanted to just point to a handout that I think all of you have gotten or have access to, where these are some of the general recommendations that I give to improve quality of life in my patients and care partners. So I hope that you take a look. I touched on some of them, but not all of them. And so just wanted to include that. Thanks so much.